The third talk today. Yes, Dr. Harjeet, please. Can I ask just one more question? We have seen Dr. Ashwini doing classical Whipples and Dr. Mahendra doing pylorus preserving. Any quick comments or thoughts from any of the panel, any of the experts here, please? TD sir, what do you do? Classical or pylorus preserving?
So I am not doing laparoscopy. Harjeet does it, and only when I'm in problem I do this thing. One thesis we did a pyloric ring exclusion with Dr. Vikas. Otherwise, I do pylorus preserving. And
Okay.
when there is any issue, sometimes duodenum gets a little bit more devascularized, then only. Otherwise, my choice is pylorus preserving.
Dr. Ashwini, you do classical always?
Always classical.
Always classical.
He's a classical surgeon.
Sir. Sitaram sir, what are your thoughts? Just a quick comment regarding pylorus preserving versus classical.
So, first of all, I want to thank Professor Kapoor and Jaipur Surgical Tutorial team for giving me this opportunity. And good evening, everyone. So, after seeing the wonderful demonstration of the pancreatico duodenectomy by robotic and Whipples, so now we'll discuss. So, what should be extent of lymphadenectomy when we are doing a pancreatico duodenectomy? So, as we all know that pancreatico duodenectomy is a complex surgical procedure and associated with a lot of morbidity, and but this procedure has evolved over a year. So, but still, the optimal lymphadenectomy in pancreatico duodenectomy is disputed. So, why is disputed? Because if you see the literature from the Whipples was started, there was a different nomenclature used, different definition used, different classification used for the lymph node stations and type of lymphadenectomy. So that means it's very difficult to compare. Even a surgeon which is saying I'm doing the standard lymphadenectomy and the other surgeon is doing the standard lymphadenectomy. So these lymphadenectomy may be different between the two surgeons because of the difference in the nomenclature and the classification. So it is very difficult to compare the two studies when they are few years apart. The second thing is surgical technique may differ between the surgeon and center. So we are using the same name for the lymphadenectomy, but actually the surgeons are not doing the same lymphadenectomy. So the outcome is very difficult to compare. The standardization of this procedure in the form of lymphadenectomy is, the Whipples has been standardized everywhere, but for lymphadenectomy, it is not achieved across all the centers. The second difficulty is the adjuvant treatment, because over a time, the different adjuvant treatment has been used and different type of lymphadenectomy has been used. So these are another biasing factors in comparing the actual role of lymphadenectomy in the survival of pancreatic duodenectomy. So, for the nomenclature issue, the Japanese Society of the Pancreatic Surgery, they try to devise a nomenclature for peripancreatic lymph node in 2003. So the nomenclature is almost same as we use in the gastric malignancy, but it is very important to understand this nomenclature. So let's revise quickly. The station 7 is the left gastric. Common hepatic artery is divided into two, that is 8A and 8P. 8A means anterior node, 8P means posterior node. Celiac axis is 9. Splenic hilum nodes are station 10. Splenic artery are divided into two, that is proximal is 11P and distal is 11D. Hepaticoduodenal lymph nodes is important to understand. 12A is along the artery, 12B is along the bile duct, C is along the cystic duct, P is along the portal vein, and H is also described in the hilum. Very important node station which is important for the pancreatico duodenectomy, the station 13 means these are the node which are retropancreatic behind the pancreatic head. SMA node is along the station 14 is lymph node along the SMA. Aorta cable is station 16. The another station which is important is the 17, which is anterior lymph nodes on the anterior surface of the pancreas, that has been labeled as 17A, which is more superior, and 17B, which is more inferior. The lymph node along the inferior border of the pancreas are classified as 18, which is usually not a part of pancreatic duodenectomy, but can be used. These lymph node stations are important when we are doing the distal pancreatectomy. So see this heterogeneity in the nomenclature of lymphadenectomy. So these are the four major trials which compare the standard lymphadenectomy and the extended lymphadenectomy over a different period of time. Here you can see in the standard lymphadenectomy, the lymph node stations are different between the different studies. So the outcome is very difficult to compare between the two studies. Similarly, in the extended group also, the lymph node stations, they are not similar between the all 4 studies. So they are different for the different studies. So then, because there was no standardization, so then efforts was done by the international study group of the pancreatic surgery in 2014. The experts sat together and they made a consensus statement, and they defined what is the standard lymphadenectomy in pancreaticoduodenectomy. So this is applicable to both pancreatic tumors and the periampullary malignancies. So we'll discuss what is standard lymphadenectomy in pancreaticoduodenectomy. So we'll discuss one by one these nodes, how important these nodes are. So station 13 and station 17, when this consensus was made, there was no dispute on these lymph nodes. So all agreed, because these lymph nodes are the part of the specimen. So these lymph nodes are the anterior, along the anterior surface of the pancreas is a 13A and 13B. And along the posterior, on the posterior surface is a 13A and 13B, and on the anterior surface is a 17A and 17B. And these are most common nodes. Around 40 to 50% of the positivity is seen in these nodes only. The second group is the important group is the SMA node, that is called the station 14. So they are divided into 14P. P means proximal nodes and D means distal nodes. So in the advanced tumor, this is the most common site of recurrence. This uncinate part is the most common site of recurrence. And in standard lymphadenectomy, the standard dissection should be, as Dr. Ashwani and Dr. Narvaria showed, that it should be along the right lateral side of the SMA. No circumferential dissection. Definitely it is associated with increased morbidity, and there is no survival advantage. So this is one clip which we did, which I'm showing for one of our patient who underwent a periampullary, case of a periampullary tumor and underwent a pancreaticoduodenectomy. So all resection has been done. So this is a part when you are saying this is the SMV, this is the formation of the portal vein. Here you can see this is SMA, this is mesopancreas, and this is the uncinate process. So we'll see how we take this node. So here you can see the IPD has been ligated, this clipped. So we are going along the right border of the SMA, and here you can see all the tissue are taken along with the specimen. So here you can see this is SMA, here is a mesopancreas, and this is ligatic IPDA. So this should be our dissection plane. The right wall of the artery should be seen. So this completes all station 14 lymph node dissection. So the another station is a celiac axis. So in routine lymphadenectomy or standard lymphadenectomy, there is no role of celiac axis lymph node dissection. Another important lymph node station is a station, the lymph node in the hepaticoduodenal ligament. Basically, in the hepaticoduodenal ligament, the lymph node stations are station 12. 12 means those stations which are close to the CBD and the portal vein. And the distal location of the hepaticoduodenal ligament is a station 8. 8 means along the common hepatic artery, suprapyloric and the infrapyloric lymph nodes. So why I combine these lymph nodes together is because when we do a lymphadenectomy in pancreaticoduodenectomy, we take these lymph nodes usually together as a part of specimen. So what that consensus statement said is that standard lymph node in HDL should include station 5 and 6. So it is little bit disputed, 5 and 6. In some studies, they don't take it as a part of standard lymphadenectomy. But in this consensus statement, they said 5 and 6 should be a part of standard lymphadenectomy. 8A means only anterior lymph node along the common hepatic artery. 12P, B, lymph node along the bile duct, and C is along the lymph node in the area of cystic duct. So there is, in standard lymphadenectomy, there is no role of 8P dissection, 12A or 12P means no dissection around the portal vein or along the arteries. So what should be upper extent of lymphadenectomy when you are doing the HDL dissection? The upper extent is where this is the right hepatic artery. So these are the lymph node station which you are supposed to take. So this is the right hepatic artery. So you are supposed to take everything below the right hepatic artery. So your upper resection limit is the right hepatic artery. So this is a small video clip of the same patient which is showing the station 8 dissection, lymph node station 8 dissection. So here you can see the superior border of the pancreas. So this is a CHA lymph node. So we are dissecting over the common hepatic artery with the bipolar scissors. So here you can see the whole tissue along the anterior to the common hepatic artery is taken. So CHA node. So this is all lymph nodes along the common hepatic artery anteriorly. So usually we don't loop the common hepatic artery and don't do the posterior dissection along the common hepatic artery. So after this lymph node, your CHA is clearly visible. Now it's very easy to dissect the GDA. Once you have seen the CHA like this, then you can clearly see the GDA and you can clip it and ligate. So then your dissection, once you have done the CHA dissection, since CHA lymph node dissection, you have ligated the GDA, then your dissection goes to the hepatoduodenal ligament. So here we are in the HDL. Here you can see we are dissecting the calyx. So you are supposed to take, so this is lymph node at the cystic duct. So you are supposed to take this lymph node along the specimen. So maybe towards the gallbladder side or towards the specimen side. So the CPD has been looped. We are using ICG for the better identification. So this is the GDA. There is another patient in which we are ligating the GDA. So once the GDA is ligated, here you can see that we are taking all the tissue. This is all the tissue from the right of the portal vein towards the specimen. So this is, here you can see this is the portal vein. So the CBD, the upper end is we do temporary clipping of the CBD so that there should not be any bile spillage. So here you can see all the lymphatic tissues and all the lymph node has been taken along with the CBD with the specimen. So this is the clearance of HDA, means 12P, 12B, 12C, 8A, and in this patient we did a classical PD. So 5 and 6 is also included into the specimen. So this is what a standard lymphadenectomy in pancreaticoduodenectomy is. That's already discussed. Station 12, station 5, station 6, 8A, station 13, 17, and station 14 only on the right side of the SMA. 8P and 16A is debatable, so I will not go into that debate, but we can discuss if there will be a time. So what is extended lymphadenectomy? Extended lymphadenectomy is we do what is done in the standard lymphadenectomy. Other than this, the common hepatic artery is, we also include 8P in extended lymphadenectomy. Celiac artery lymph nodes are also dissected in extended lymphadenectomy. Superior mesenteric artery, both. You are supposed to do the circumferential dissection in the superior mesenteric vessel when you are planning the extended lymphadenectomy. All the 16 lymph nodes, 16A and 16B, means paraaortic lymph node from celiac axis to IMA. Skeletonization, we just dissected the, in standard lymphadenectomy, we dissected the lymph node along the bile duct and the cystic duct, but here you are supposed to, in extended lymphadenectomy, you are supposed to skeletonize everything, means artery, bile duct and the portal vein. 12A artery, B is bile duct, and 12P is the portal vein. So other than this node, what makes lymphadenectomy, extended lymphadenectomy, is the nerve dissection circumferentially along the vessels. So you are supposed to dissect along the CHA and SMA, and you have to bear it completely from the nerve tissues or the nerve plexus. Even in the standard lymphadenectomy, in many studies, the only semi-circumferential dissection of the celiac axis has been described on the right side. So after this, I will be discussing few trials and studies which will highlight that what should be an ideal lymphadenectomy in pancreaticoduodenectomy. So these are the prospective study, but these are the non-randomized trial. So here you can see there is a one trial which was published very early, did not show any advantage of doing the extended lymphadenectomy, but there was another trial which showed advantage, but in this trial the chemo radiation therapy has been used, and the another 3 trial they favored that the extended lymphadenectomy is beneficial in patient with a pancreaticoduodenectomy. So still with these studies there is a debate. So then there was a, till now I searched the literature, till date there are 5 randomized trials which had been published in the pancreatic tumor between standard and extended lymphadenectomy. So this is one of the trial in 2015 which was published from the Mayo Center from USA. They compared the standard lymphadenectomy with the extended lymph node dissection, and 49 standard versus 39 extended lymphadenectomy. Lymph node harvesting was definitely better in patient who had extended lymphadenectomy, but in this study, there was no significant difference in the major morbidity in patients between the two groups. But what they found is there is a survival curve. They did not find any significant difference of overall survival in patient who underwent the extended lymphadenectomy. This is another trial. Long-term results of that trial has been published from the Japan in 2012, which is a multicentric trial which compared 51 patients with a standard lymphadenectomy with the extended, and again, the lymph node retrieval was definitely better in extended, but and post-operative morbidity and mortality was similar. But severe diarrhea was more common in the extended group. If you'll see the survival analysis, there was no significant difference in the disease-free survival and overall survival between the two groups. They also compared patients who had a node positivity and node negativity. Even the node positive patient did not show any survival advantage in patient who underwent the extended lymphadenectomy. This is another trial which was published from Korea, in which 83 patients of the was compared with 86 patients. This is the lymphadenectomy what they used in their study. Here they used, in standard lymphadenectomy, they used the 12B and 12C, station 13 and station 17. So in this trial, they did not included 5 and 6 as a part of standard lymphadenectomy. In extended lymphadenectomy, all lymph node has been harvested and the celiac and SMA plexus, only right side of the artery was dissected. So if you see the survival analysis, there is no significant difference in survival between the two. If you compare the extended versus standard, there is, even in the node positivity, those patients who had a node positivity did not show any significant difference. But the difference was when they did a standard lymphadenectomy and when they used the adjuvant treatment, the survival was much better in patients with the standard lymphadenectomy and adjuvant treatment. And there was no significant difference when the extended lymphadenectomy has been combined with the adjuvant treatment. So the meta-analysis of many randomized trial and prospective trial did not show any significant benefit of doing the extended lymphadenectomy in patients who are undergoing the routine pancreaticoduodenectomy. I did not deliberately discuss the borderline resectable tumors or because I think that talk will be covered by someone else tomorrow. So there's no significant long-term survival in patients who underwent extended resections in pancreaticoduodenectomy. So with this, I conclude that the standardization of the nomenclature of a lymphadenectomy is important for the accurate comparison between the studies. So none of the studies showed that the extended lymph node dissection along with the nerve plexus dissection had an advantage of survival. So there was no major difference in morbidity, but definitely the morbidity is little more with the extended lymph node dissection. And the last trial showed that if we'll combine the standard lymphadenectomy with appropriate adjuvant treatment, that improves the survival. Thank you.
Thank you, Dr. Harjeet, for the wonderful, very crisp and, it was very nice, especially the presentation of data and everything. Very nice talk. And questions from the panel, please.
So, Harjeet, please correct me if I am wrong. For the benefit of students, the HDL dissection for pancreas is not same as gallbladder, because in gallbladder we go right up to the hilum and everything is skeletonized. Isn't it? So there is a difference. This question is often asked from the students, that what is the difference in the HDL lymphadenectomy between, say, gallbladder or cholangiocarcinoma versus PD. So PD, as you rightly said, it is mainly on the anterior surface of the CBD and hepatic artery and caudal to the level of the right hepatic artery. We don't go behind the portal vein.
We don't go,
Now this, although we will discuss this tomorrow, but when you say that you are doing only the lymph nodal dissection on the right surface or the right border of the SMA, so what is the difference between this and what we are going to discuss tomorrow in the new philosophy or the new technique of arterial divestment?
So in arterial divestment means we are dissecting onto the SMA. So you are supposed to loop because first of all, the aim is to get a R0 resections. So that's why we are doing the artery first. So I think the dissection is definitely different. You are supposed to loop the supramesenteric vein. You are supposed to loop the SMV, or sometimes you need a resection of these vessels. So we are going into the plane where, because there is a lot of tissue on the SMA, the nerve plexus and everything, there is a lot of tissue. So we are supposed to dissect onto the tissue to bear the SMA completely. And sometime when you're bearing this tissue, you are supposed to go, because that's how it has been explained, different level 1, 2, and 3, depending upon the involvement of the uncinate and the involvement of the tumor. So in these, we do dissection onto the SMA, we do a nerve plexus dissection, and we bare the artery completely. So here is only, I think, the right part. We don't loop the SMV, we don't loop the SMA.
A philosophical question which maybe you can take, or maybe Dr. Sitaram or Dr. Yadav can also take, that when we say that we are doing lymph node dissection of a particular group, how can we say that we will do only the right side and not the left side? They belong to the same group. So does it have any scientific basis, or it is more for logistics, it is more for technical ease, and it is more to decrease the complications which are associated with divestment of the SMA in terms of neural and lymphatic complications? TD,
So I just wanted to say, sir, initial reports by Ishikawa, and he described total bearing of the SMA, and basically in a patients where it was a pancreatic head tumor, not the periampullary tumor,
Yes.
and because of that, going and taking all the neurovascular bundles from all around the SMA, it was found to have a lots of diarrhea, and patients were subjected to TPN and some sort of sometimes even acute right, and that's what the big this comment given for his technique. Second person, which is Japanese, I am forgetting the name. He was president of the our association of APH PBA. He used to take SMA and resect and then dissect. But this part also has lots of problems in the post-op. So when we are talking about what Dr. Harjeet is saying, we are talking about usually first is that most of the lymph nodes are present in that area. And when we are doing only on the right side, we are talking more of the uncinate process and trying to have the margin negative in a pancreatic head tumors. But if you are going toward the left of the SMA, in between the SMA and that particular tissue, some people come from left to the right. But to have the same type of outcome, then obviously a whole neurovascular bundle is taken off, and that's why probably more and more diarrhea. But the first article, I think Dr. Harjeet covered all the recent, but when I was probably registered, then first RCT was done in Hopkins only, extended lymphadenectomy with standard, and
98, yes.
they could not find any difference in the survival in a pancreatic head tumor. So we are not talking about periampullary, where you don't need to take all the tissue away from the SMA.
So one more
So
question.
I think, sir, I think it's a very valid question, because I think in SMA dissection, so why we are talking about the right side only, I think maybe is actually a lymph node, or whether it's an attempt to achieve a R0 resection. So maybe when you are, because why we are saying you because ultimately the why recurrence is there, because the uncinate tumors which is in close proximity to SMA, it will not go till the supramesenteric artery, there is high chance of recurrences. So I think by saying so that you do all the lymph node dissection along the right side of SMA, means once we are achieving the lymph node clearance on the right side, second we are achieving the better margin on the SMA. So I think that's why I think this has been described here. You do this resection, but definitely if the lymph node involvement is there, and then whether they are we are converting into the survival advantage, that's we are not sure.
Dr. Sitaram wants to say something.
Sorry, I didn't want to say anything, but since you asked, I think the right side of the supramesenteric artery, I think philosophically that was reached by saying that you can't go beyond that, because you can't take the supramesenteric artery. So you stop with the right side of the supramesenteric artery. But I think if you have nodes right or left in the region of the supramesenteric artery which have tumor in them, that patient has gone beyond the limits of this operation. You can't cure that patient with this operation. I don't know whether I've expressed what is in my mind. What occurs?
Sir, one more important point. I think we should also understand the anatomy of the uncinate process and where its mesentery is going and inserting. So if you see the anatomy, three different types of insertion of the uncinate in the retroperitoneum. So one just reaches the most easy one for the surgeon and everybody reaches, and that to the right of the SMA. Another goes behind the SMA, and third part, which is the most complicated, what probably Dr. Kishore conveyed, it goes beyond even to the left of the SMA, and that meso pancreas has its congenital vascularity coming from the SMA, and because of that, probably it has its lymph nodal presence also in that particular area. So that's why probably, and obviously commonest one is type 1 insertion. So probably that taking in a head of pancreas tumor, taking that particular a part going up to the right of the suffices. But when it type 2 and type 3 is there, especially type 3 is there, then probably encircling the SMA and trying to take the lymph node. So maybe a huge, but I have one experience. I removed the specimen, and then I found a node on the left of the SMA in one of the father of my student when I was in government medical college, and this I did in PGI. Then I had to remove the lymph node after my resection, and patient received adjuvant, but he is surviving. So probably lymph nodal dissection, that was positive. Sorry, that was positive also, sir. So positivity, since after removal, before removal, I could not realize that there is a lymph node. But the moment we remove the specimen, we realized that there is a nodal tissue. So since everything was in front, I dissected everything off. So these are the probably reason. That's why right is more and more described because of the mesopancreas. More important is mesopancreas insertion, which probably by any anatomy we are not able to see, except that you while doing the operation we find that mesopancreas is going inserting in the retroperitoneum, crossing all the way behind SMA and left of the aorta also. Sometimes is good. Then we call para-aortic lymph node, which is usually supposed to be not curative resection once it is involved.
So, sir, I don't know whether your removal of that lymph node helped in survival of this patient, or removal of that removal of node and better stagings. Maybe
Yeah.
I don't know whether other node was, so that means we have staged it better. Means we know it's an N1 disease and we give adjuvant treatment. So that's why I'm saying it's very difficult in literature to say that whether it's only node which improved the survival or it's a better staging and then adjuvant treatment which ultimately resulted in the better survival.
Biology also, maybe location, that's why tumor was that area. Biology also. So all these factors are important. But as I said, suppose I would have palpated and node was not that before operation, I would have hesitated in doing pancreatico. But once I removed the specimen, I saw that lymph node. So we went ahead and did it. So all these things, as I said, had largely, but we are not doing that meticulous this thing. But you also remember that after that, I met our pathology department and we did that margin in pancreatico, and with the Mohan, we did one thesis also. Yes,
one practical question, sir.
Yes.
Sir, one practical question, but regarding the practices, do we have a regular system of separating all these stations, lymph nodes, once a specimen is out and sending them separately for histopathology, or the entire specimen in toto is sent to the pathology, just individual units? Because what we do in our practice is, if a new pathologist, if a system changes there, the first 5 or 7 ripples we go to them. We talk to them, we discuss the grossing, and we be with them during grossings. We will, orient the specimen anatomically and tell them these are all the stations required. Otherwise, we don't actually do a separate, 5, 6, 12. We don't remove it separately. And I don't know what are your practices, sir?
So we take lymph nodes like we suppose CHA is coming separately, we do take it separately. So node which we are taking separately, we label it separately and we send it separately. But after resection, we don't ourselves do the specimen dissection and we don't separate the node. And even we, in our pathology department, is a very big department, so it's very difficult to teach it and everyone. So thus we have to rely what they reported. So in our center, we don't practice this, but I think that's the ideal way you did it. So that it should be done. But in our center, we are not doing like this.
No, we are not separating the lymph nodes. We will just,
No, but you're
new
teaching your,
pathologist joining.
but you're teaching your pathologists also, because it's important. You have to tell them what is the important is these nodes and how to dissect it. And maybe, I don't know, in our department, maybe a junior most person is doing the grossing of the specimen. So that's very important. The grossing of specimen is very important when you are really want to see the staging and lymph nodal involvement.
So Dr.
Probably,
I was with Guru Handa for some time. So I saw a person who has operated. He will go to the pathology department next day in the morning and sit with the pathologist and tell these are the areas we want to, as you said, but obviously we have not done. But I think Dr. Asim Das, when we discussed with him, he made a little bit of a standard, because nowadays when we are getting our reports, then they describe all the margins very clearly. This margin, otherwise earlier they were not doing it. Many
even margin they were not doing.
Margins were not there.
But now the margin they are very clearly saying.
Very clearly they describe.
They are clearly describe all the margins.
Unless we mark the margins in the specimen, once it is put in formalin, it is virtually impossible for the pathologist to know which margin is what. So either we ink or we put separate sutures, long, short, single, double, whatever. And all those details have to be mentioned by the resident in the requisition form. And ideal, of course, is that you discuss the specimen with the pathologist, but it's important. But again, I think in most centers, majority of the resections are for periampullary, where probably margins are not that important. But in head, pancreas, or in uncinate, it definitely becomes important.
In South, it's more important, sir.
Okay, yeah, CP. So we have 2 more minutes. Arun, any concluding comments you would like to make as the moderator?
Sir, the first talk, we saw beautiful video of robotic pancreatic duodenectomy, very well narrated, all the important things, and the graduation from open to robo-assisted Whipples, we have seen from Dr. Ashwini Kudari. Then moving on to Dr. Narvaria, a beautiful video, almost all the steps in detail, the suturing techniques, focusing more on the technical aspects. We have seen the entire spectrum of laparoscopic pancreatic duodenectomy. And the third one from Dr. Harjeet, we have seen actually he exposed the heterogeneity in labeling, in using the terms, in dissections, and the entire heterogeneity among surgeons, among units, from the very same surgeon in different patients with different time of his skill and excellence. So we've seen the heterogeneity of lymph node issue in Whipples, but we could get some good points. These are the important notes that we have to take it up, and we have to label it whenever it is possible. And I think the practical issues have been very well covered. And over to you, sir, for the final concluding remarks.
No, I think we just have 1 more minute. I have nothing more to say about Ashwini and Mahendra, but I'm very happy to see Harjeet maturing into a pancreatic surgeon, and credit to some extent probably goes to TD, and thank you, TD, for promoting him, for recommending him. Mahendra, you want to say something? You are muted. Unmute karo.
I just wanted to thank you in believing me, and so far people only remember me as a bariatric surgeon.
You presented yourself as a bariatric surgeon. You whole presentation 20 times you said I do bariatric. So don't blame others. You are to be blamed.
So thank you for allowing me to present this. Though pancreas, whatever I have done, I just shown you. And once again, and
thank you. So we started at 7, we are at 9, so we will close. And I would like to thank Arun for accepting to moderate, because I had some personal commitments in between. And thanks to Ashwini, Mahendra, and Harjeet for presenting. Thank you, Dr. Sitaram, for once again being present throughout the masterclass. We hope to see you in all masterclasses and give your words of wisdom to all the young surgeons and students. Thank you, TD. Thank you.
Thank you,
We will close the session. And thanks to Avinash's team in Ahmedabad for providing all the technical support. And they have been religiously recording and putting all these videos. And I have to say that although the live attendance is not very high, But by tomorrow morning, we will have hundreds of views of these videos. And some of the masterclass videos, including the one on bile duct injury, are almost reaching 1,000 views. So I'm very happy that all the efforts put in by everybody are being used by students and practicing surgeons. Thank you all very much. Good night.
Thanks
Thank
a
you,
lot.
sir.